There is an article published, I guess, last year by Charles Nemiroff at the University of Texas. Charlie does a lot of psilocybin work, and he's been critical of those writers who talk about set and setting and the healing and these factors that we just mentioned. Um, because there isn't a manual and there is not a way of being able to reproduce or depict
Even.
what happens here. I
Mhm.
think Charlie, with all due respect, I know him as a friend, really misses what happens. It's, that he misses just sitting with somebody who's on the influence of these medicines or in another state of mind, has a person with them who they trust and can feel comforted by. And I think it may there not be a manual for that, but if you sit with that kind of person and you provide that, that in and of itself is healing. And that's some of the work I think we have to do. So there's a hand up. I'm uh, Ryder.
There we go. Dr. Xenakis, thank you so much. This has been a very interesting talk. I have a lot of notes here.
Thank you.
Um, I would like you to piggyback on what you were talking about just now and pose, if you have one, a solution with the current landscape of academia and how we're going to get around this obstacle of incorporating the esoteric and the actual beauty of the healing experience in a way that is reliable and valid and statistically significant.
So let me just throw this out, and I really want you all are much younger and smarter, so I need your bright ideas here. I would use videotape and audio and apply AI and apply also similar kind of AI intelligence to the videos. For example, and I've sort of done this before. I have done it with language and AI, and we've done some early projects to show, in fact, what language people use who are responders and what language people use that don't are responders, and you can cluster it and you can find keywords. It's not NLP, it's the kind of stuff that you see in Chat GBT. I think we could also do it in video. So the idea of a control, I can't fathom how you would have a control if I'm putting somebody under, giving them psilocybin, MDMA, or ketamine. I could video that, and I could video the person under the influence of the medicine, and I could video the person who's the so-called control under the influence of the medicine, not under. And I bet you I could show you clear differences in those videos of what the relationship and what the relationship is between the therapist or the doctor and the client or the patient. And you could see it on those videos. And I think we could break it down and say, even though you think nothing's happening here, even though this person sitting with this patient is not following some manual that is an evidence-based therapy, whatever that myth is, I can show you by these videos something has happened. You know, I mean, just like I'm a child and adolescent psychiatrist, just sort of I did the training. I don't practice as much in that field, but there's been all these studies in development of what good mothering is and not good mothering, where they've looked at mothers with their babies or toddlers and can show the differences of how they relate just in eye contact, in holding, in responsiveness, and other ways that they're being touched, and the facial expressions. I think we can do all that. I think the technology is out there. And that's the kind of thing we're going to have to do. We're going to have to get money for it because I don't think we're going to get this money from NIMH, by the way, because this is going to break the mold of what they've been doing. But I think the tools are there.
Do you think that we could reverse engineer a novel research design for psychedelics using video studies and kind of go backwards and create an entire model of research design from videos like what you just described?
I think that's a really good thought. So let's say we've got a lot of videos, right, from maps, and if they would disclose them, we've got a lot from psilocybin. We have ways of saying who is a good outcome or not a good outcome. So we've got that there. And then we could take those good outcomes and look at the videos and say, what's the difference in what happened there with those that we're saying were not a good outcome? So that's a great idea. I'll follow you on that.
Oh, well, I'll be in touch. Thank you so much.
Sure. Others.
Yes, Philip.
Um,
You're
I'm interested in what support you feel you have within the military for your position, because I think that the military is a entity that is somewhat neutral politically when it comes to Congress and the political side of this. And so I wonder sort of where you think the support is within the military.
That's a good, really very interesting challenge here about the military. Let me see how I can start with it. One of the problems we've always had as military doctors has been, you have to let me think out loud, but I have thought this through to some extent, is that if you're so broken that you're going to need an intense treatment, it's probably better for us to medically retire you and send you over to the VA. So we can't expect that if you're so broken that you're going to be able to get back on the field. I mean, essentially think of the military as an elite sport. And each of those who serve are really athletes on the field. Now, in doing that, there's a point that you have been so injured that we're no longer going to call you up to play. And at that point, we're going to send you over to the VA. On the other hand, if we've invested, as we have with certain particularly elite forces, so much in you, and you have such an amazing special skill, it may be, and you've been doing it for such a long time that you are a real, exceptional special individual. Maybe I need to make a special effort to heal you and keep you in the game and keep you on the team. Now, there is a political part to that, because we don't want our enemy to know that we've got broken soldiers. So we have to find a way to do that in our closed doors and in our closed environment, and we've not exposed ourselves. Sometimes we haven't even exposed ourselves to our own political tension within the Congress. Are we going to pay for that or not? The folks, as the military has become so much more sophisticated in so many different ways, the idea of keeping people who have been trained and experienced and are exceptional on board has a lot more support and momentum. If you're special forces or you're cyber or you're in some other particular specialty, that is really important. And if I can keep you there and keep you functional, then I can do that. How I do that within the military right now, of course, if it says that they're supporting psychedelics, gets itself also politically exposed in a negative way. Right? Because
Yeah.
it's a problem.
But it's my understanding, and I may be incorrect on this, that the military has supported a certain amount of research, although they don't want to take any credit for it. They won't even admit that they're doing it. But I do feel that they realize that there's a potential here, and I think to some extent they have supported it. But as I said, they don't want to take any credit or even be recognized. Just
It
for the
all has to be
political.
undercover. You're 100% right. It has to be at this point undercover that we're doing it.
Yeah, that's what I was told.
Yep. So, and remember, our history also complicates what we do here. And that goes back to the 50s and 60s. You've probably seen the movies of what happened at Aberdeen Proving Grounds.
Yeah.
And then actually, a New Yorker had an article on the brother of one of my residency classmates. My residency classmates with Bob Ketchum, his older brother, Jim Ketchum, was doing those experiments, and they really tried to hurt his career after that. So there's a lot. I mean, this is a touchy political thing.
Mm-hmm. Thank you.
Sure.
Dr. Xenakis, can I follow on that thread? Just because we were discussing a little bit like barriers to seeking help, and one of the things that I kind of suspect is what you're talking about. When people come back from wartime with trauma, that there may be a stigma attached to them seeking help. Kind of being untough or unmanly, and B, worrying about being sidelined, taken out of the game. Do you see any kind of way to develop a protocol so that that doesn't happen as much as, obviously if someone needs to be taken out, that's fine. But I think there's a lot of people who could get help who are afraid to get help. And to me, I hate things being mandatory, but like, is there a system where veterans come back and have to go through some kind of protocol before re-entering society?
We don't have a transition. So back to your last question is, and I think we should. I think we should have a transition system for almost all our military, and that one is more sophisticated than what we do now. Because a lot of veterans, we were talking about it in our small group. I mean, that transition, if you come in at 18, 19, 20 years old, you serve 4 or 5 years, those are big developmental years. That's really important. And you've come in to do something that you otherwise would not be able to do. Maybe if only it is so that you can get, funding support for college, but you end up being part of a team. And in those developmental years, being part of that team and then seeing that team has a purpose and all the bonds that you get there, and you have a lifestyle and you got a routine and you got some discipline to your life, that's a big deal from, think of young men and women between 18 and 25. To then all of a sudden have them exit and be in a completely different world and not be a member of a team, not have those connections, not have those routines, that's really disorienting. And I think we need to do a better job in terms of that transition so that they understand the world they're getting into and how they would become, because it's important to them, right? How they do become part of a team, how they do find purpose, right? I mean, yeah, the war is confusing and maybe we weren't doing the right thing. I mean, I got my own questions about Vietnam and Iraq and Afghanistan. But at least we all said to each other, hey, look, we got a purpose here. We know what we're here to do. And I think that these young men and women leaving, that's a big issue. Now, the other point is, your 2 points are excellent in terms of just, I don't know if it's stigma or pride. I mean, who wants to be told that you're broken in any way, that you're broken? Not just psychologically. I mean, you have an injury. I mean, you know how it is. It's sort of human nature. We deny, a lot of us deny our pain. A lot of us deny, I mean, how many people, are really having cardiac symptoms and they deny it and end up dying of an MI. I mean, it's just natural that those kinds of things happen. And it is a worry that in a military that may be downsizing. We saw this repeatedly, particularly after the first Gulf War. We're probably seeing it. We saw it at other times, that if you somehow are marked as having something that's a problem, then you're going to be asked to leave one way or another. And I think I think that's where we've got to, as military leaders in our current leadership, that's where we command climate comes into play. That we know that you've been, in this case, we've had a military that's been through 20 years of war. There's no way that you can't be broken one way or another. There's no way that you can't be injured. Um, but we're going to take care of you and we're going to do everything you can because you're an important, valuable member of our team. And we're going to make a commitment to you, which means we've got to be pretty mature and sophisticated about the way we do that. But that is where the art of command comes into play, as much as what might be the mechanisms that we take care of our soldiers.
Thank you.
Hi, I'm Christine. So my question was, so do you think this doesn't really have the potential to roll out at the VA level?
Oh, no, I think it does. I think that the VA is not ready to roll it out for a while, because I think that they are going to have to study and come up with ways that they feel comfortable that they can set up the clinical services and make them available to the people who need it. I think that they probably have a judgment, an estimate that there's many, many more thousands of people who would come to the clinics for treatment than they're ready to provide the services. They have to decide, are they going to reconfigure their current clinics or are they going to set up separate clinics? There's some consideration of, once they've done that, how are they going to follow up? Are they going to, now fortunately we do have tools and wearables where we could follow up, but they've got to figure that out. They've got a huge training mission here of training practitioners. What's going to be done in-house? What's going to be done contract? VA, frankly, following this election, VA may come under very heavy pressure to contract out and downsize as people are looking for efficiencies. Then what's going to happen? And then how do you identify if that happens? In that scenario, how do you identify those contract clinics that you have confidence are providing the services the way they want to be provided? And what are the criteria that you select and award the contracts? So lots to juggle here. My efforts started in 2021, where I was able to contact and meet with the Assistant Secretary of Health, Rachel Levine, Admiral Levine, and with White House people to say, look, I think you all need to get ahead of this power curve. This is rolling out. I was completely unsuccessful, so who knows? I wasn't able to carry the ball. And I think we're looking at 4, 5, 6, maybe longer years before this rolls out. I'm very disappointed. We got my generation. We dropped the ball on Agent Orange and a couple other things. I think we've dropped the ball on traumatic brain injury, and have integrated care between TBI, PTSD, sleep problems. Almost all these soldiers who've had TBIs have sleep problems. And I don't see where we've got real good integrated care centers there. So I think we got a lot of work to do here.
Thank you.
You, this is a kind of a off-ball kind of idea, but do you think John Stewart might be a great advocate to sort of get this ball rolling? Because he has helped veterans in many different ways. And I think if anyone at that level would highlight this therapy as an option to be researched and performed, whether people might listen.
I think I mean, if you've got contacts and you've got a way of getting there, we can get the story. I think that he's terrific, you
Yeah.
know? So, I mean, I think that'd be great. I mean, I think we have our homework to do in terms of saying this is what we think would be a modal kind of clinic or a model kind of clinic. Maybe the research that Ryder was telling us needs to be done.
Mhm.
We've got a lot of information, right? We got a lot of people already that have done a lot of work. One of the things I wanted to do, I was the last executive director for APA, and that organization collapsed, and for other reasons, I mean, sort of, but similar reasons. Was I wanted to, as part of that, to have a professional practice association and get as many practitioners together and say, based on our experience and knowledge, let's come up with what we think are the best practices as we see them now. I mean, APA and Brain Futures did publish professional practice guidelines. That's a really good first step. There's plenty of other people out there, and we could do this. I had proposed about $1 million project to come up with the best practices guidelines, and I couldn't get the funding for it. I mean, the money was going to go to Lycos because they said we don't need this. We've got it all figured out. We know what we're going to do, and so it fell apart. But I think that's what we should. I think that's a path.
Hi, Dr. Xenakis. You don't have to answer this question, but it's a burning one for me, which is, what is your backstory? How did you come to be a psychedelics advocate? Anything that you want to share along those lines?
Well, I mean, the short of it is, when I started medical school, 1970, I wasn't going to be a psychiatrist. I wasn't sure what I was going to do. But they had a combined accelerated program in psychiatry, and I felt like if I was going to be a good doctor, I better learn as much about people and what they're doing and how they're working as I could. And so I enrolled in it in 1970. And then as time went on, I'm sorry.
Yep, sorry.
As time went on, and I was going through surgery training and internal medicine and all that, I felt like no matter what we're doing in whatever specialty area, it anchors the relationship with the patient, anchors what we do. And so I decided to train in psychiatry. And we were in San Francisco, we were doing projects with these medicines. And I had the privilege of training with Dr. Horowitz. And we were exposed to this was a time when there was some really exciting, imaginative, and creative work that was being done. And I realized these were really good thinkers.
Mhm.
And fundamentally, because I'm a clinician, I'm not a researcher, I'm not an academic. I find clinical medicine is mostly empirical. And what I want to do is, from my observations and experiences, is be able to very systematically identify what I think is going to work with the patients that I see and treat. and that in that way, the science, I'm not comfortable with our current world of evidence-based medicine because I think it makes the science has become tyrannical. A science should inform clinical decision making that is much bigger than that. The whole of clinical decision making, the sum is much bigger, or the whole is much bigger than the sum of the parts. And so I've maintained that interest. I am from the 70s. I maintained an interest in looking at better ways to do things. And we had some better ways, even though psychedelics actually with Nixon in 72 were shut down. We still were doing Amytal interviews. We were still looking at other ways of inducing altered states with hypnosis. We still had other things that really taught us meditation, really taught us that this was important. And I tried to be a good doctor, and in being a good doctor was going to be a good empiricist in that way. And also my teacher said, you want to be a good doctor, the more patients you see, the better doctor you're going to be. So I try to maintain an active practice. And then now when this, the field, there was a resurgence in 2020 when I first got re-exposed to it, and I realized that there was a resurgence. I said, it's time to revisit this.
Mm-hmm.
And particularly since I found it very frustrating to help my patients with the current conventions of psychopharmacology and manualized treatments. My patients were not getting better. And, I'm probably just a mediocre doctor and probably in somebody else's hands are better, but I realized I needed something more if I was going to help these men and women. So that's if there's a backstory, that's the backstory, and all this, San Francisco was wild. I mean, if any of you were around, it was wild, but it was terrific, right? It was like so creative.
Yeah.
Philip, are you?
Hi, General Xenakis.
Hey.
How are you doing?
Good. How are you? Good to see you.
All right. Good to see you too. So I just wanted to comment on the best practice thing, because I definitely agree that is probably the route that's going to get us into the VA. I don't know if I think I told you about this probably, but my first organization, Ketamine Task Force, has been working now for almost 2 years to put together a protocol that can show best practices for ketamine. And we're hopefully going to be doing a research study on 250 veterans that's going to show, number one, best protocol for best results, and number two, that it's safe, like the safety, because that was the two things that the VA and that the FDA said was that there's no long-term studies on safety and there's no long-term studies on best protocol, that all the studies out there are very short. So, and we're looking to do a longitudinal study, not a double-blind study, just because you really can't blind this stuff. It's very hard to do, so it's ridiculous. So our goal is to get 250 patients to complete this study. Each patient will be treated for 1 year. And we actually came up with a fantastic protocol using a 10 loading dose series instead of 6, because you catch more of the outliers like that. And after the 10 loading doses, everyone will go on to be treated once a month for a complete year. And we're using like 1 million different questionnaires to show safety, limited side effects, things like that, which is what the FDA has basically asked for. So right now we're actually applying to the Florida legislature to try to get them to fund it. Unfortunately, last year we had applied to them and they put our package with a big veterans bill, and the whole thing got kiboshed and didn't pass through Congress. But we're going to try again this year, and hopefully we're going to do it, and hopefully we can get the study done, and hopefully we can prove once and for all that ketamine really does work and how well it works. And I really think that ketamine is going to be the drug that opens up the pathway for things like MDMA and other similar types of drugs, because it already has basic FDA approval, even though it's not for depression. But I think that is going to be the way forward.
Well, good for you. That's terrific. That's a great idea. I mean, I think we have to do that. Great.
Yeah.
And I do think it probably will open the door. And also for all the reasons too, that people figure out who you train, how you train them, if you
Exactly.
contract, I mean, all those things that are the nitty gritty stuff of how you build a new treatment program. So I think it's great. Terrific. Congratulations. Salute you.
Thank you.
Oh, Philip, go ahead.
I had one question. That you have the profession and all of that, and you assume certain things, but from my point of view, coming from the business world, I look at it strictly from an economic point of view. From my point of view, this approach potentially is the least expensive way of solving the problem for a lot of these people.
Mm.
And am I right or am I wrong on that? Because I feel that the general impression I get is this either works or it doesn't work for somebody. And you find that out fairly quickly. Whereas the normal process in psychiatry can go on for years and years, and at $300 or $400 a session and tons of costs for medications, the cost is enormous. Whereas this is much more reasonable. So I would promote it basically strictly on economics.
Yeah, look, I think that's a strong argument, the cost benefit here. The best writing has been by Elliot Marseille at Berkeley. He's looked at for some of these various modalities and treatments, and it's not only a lifetime course of treatment, and so that if you go $5,000 to $15,000 for a series of sessions, as compared to what the lifetime course of treatment is with these other modalities, you have that cost factor that plays into it. The other cost factors that really do need to be that you would understand as a businessman is, what do we have in terms of lost productivity? What do we have in terms of bringing people back? I mean, those are not mainline studies that we seem to do in the field because things get so siloed, but this is clearly something that would be very important. It also is important because in the VA, you're a lifetime patient. It's not like other managed care where there's so much rotation from one from one particular provider, insurance provider to another. Even you have some longer term ones. So I think that that's a really important factor here. And I'd like to see, there probably need to be a couple more studies done or data gathered in some ways. I'm a big promoter of having someone fund a registry. And I have talked to Tom Insel, former head of the NIMH, on that, where we collect not only the history of the treatments and all the information we need that profiles a patient medically and work-wise, but also we get this other data in terms of their productivity, their work relationships, everything else that goes into what we know would enter into cost factors. So that is another way I think that we might be able over time to make the case for why this is important.
Well, it'll be interesting. I mean, I can't say I'm a strong supporter of Musk or Trump, but if you take Musk's potential position for economies and government, you might be surprised where your support comes from. But who knows?
Who knows? You might be surprised.
Yeah, exactly.
Well, listen, I'm aware of the time. I think we could all go into the night. This has just been such an engaging conversation. I know personally I've learned so much. I just want to thank you, Dr. Xenakis, for your service to this country, for your dedication to this movement. We are so lucky to have someone of your caliber in support and pushing forward a new way to heal. The need is great, so it's a wonderful thing. And thanks to all of you for joining us. And this video, this is all of our fireside chats are on the Thank You Life YouTube channel. You can forward this to anybody that you think would be interested. I know actually this is one that I will want to watch again. Again, thank you so much. And thanks to all of you.
Thank you.
It's a great privilege. I want to
Thank
thank you
you.
all and salute you all. Thanks.
Thank you.
So much.
Bye, everyone.
Bye.
All right. Have a good evening.